ريكورد شغال. Okay. Good evening. Today I'm going to talk about the current topics in the interdisciplinary prosthodontics. Interdisciplinary approach has become an integral part of our everyday dentistry and should be given a priority as early as possible because of the prime importance of diagnosis. Interdisciplinary means that the disciplines of orthodontics, periodontics, prosthodontics, and endodontics work together in order to utilize their knowledge and specialties to formulate a comprehensive therapy that give the patient the optimal care. So it's like this piece of the puzzle. You can't have the full picture unless you have all the parts. This is my presentation topic list. I will try to talk briefly about some topics because it's a huge subject. First, I will talk about the ortho-prosthodontic collaboration, the concept of accelerated orthodontics, go through some periodontal and endodontic topics, and finally about the cloud collaboration. First, the orthodontic-prosthodontic collaboration. Patients usually require restorative treatment during or after orthodontic therapy for several reasons. Tooth size discrepancy, management of congenitally missing maxillary lateral incisors, management of a unilateral impacted canine, management of a deep bite case. Now, what is the tooth size discrepancy? Tooth size discrepancy exists when the maxillary and mandibular teeth are not in proportion with each other. This case is about a 23-year-old patient with a class 2 malocclusion associated with 5 millimeter of crowding in the mandibular arch and mild spacing distal to the maxillary canine, left maxillary canine. The patient had a retained left mandibular, primary second molar, and congenitally missing left mandibular second premolar. As you can see, the undersized lateral incisors resulted in teeth size discrepancy, in this case, maxillary deficiency and mandibular excess. Now, the interdisciplinary treatment plan of this case involved maintaining the primary molar with the possibility of future restorative work, and second, accepting the mandibular dental midline discrepancy and restoring the ideal proportion of the undersized maxillary lateral incisors by opening the space distal to the maxillary lateral incisors. So that was the first step, doing orthodontic brackets in order to open slight space distal to the maxillary lateral incisor. Now, in order to achieve an optimum aesthetic and functional outcomes, we should use digital tools in order to visualize the final position of the teeth and determine the restorative work, such as these digital diagnostic setups. And you know, the diagnostic setups were actually done at the end of the orthodontic phase. What they did here in this case, that after creating the space with the brackets, the space that was created distal to the lateral at the beginning, at the end of the orthodontic treatment, they removed the orthodontic wire and kept the brackets while they scanned the arch. So they removed the wire and kept the brackets, then scanned the arch with the brackets. They did that just in case if the patient need further or more tooth movement, because they are still in the planning phase. So back in this case, this is regarding the right side. You can see there is two diagnostic setup. The first choice was building up the lateral incisor only. And the second one is building up both the lateral incisor and the canine. And for this case, they went for the second option, which is build up the lateral incisor and the canine. Regarding the left side, digital diagnostic setup showed that it was sufficient to build up the distal surface of the maxillary left lateral incisor simply with composite restoration. And this is the final treatment outcome. You can see the good proportion of the laterals to each other and to the central incisors. The second case is about a 13-year-old female patient who presented to the orthodontic clinic with concerns about tooth crowding. Upon intraoral and radiographic examination, the left maxillary lateral incisor had malformed crown shape, this one, and type 1 dense invaginatus according to Euler's classification. And this CBCT, as you can see here, was obtained to evaluate the enamel and dentin thickness. Like the previous case, they did the digital diagnostic setup. Digital diagnostic setup was done at the end of the orthodontic treatment. Again, they removed the wire, they kept the brackets, and they scanned the arch with the brackets, just in case they need further movement. And as you can see, this is the diagnostic setup. Composite shaping, only shaping for the malformed teeth. Then two treatment options were discussed with the patient to reshape the left maxillary incisor and consolidate the space between the left maxillary incisor and the canine. There were two options, a direct resin composite restoration and indirect ceramic crown. In this case, they choose composite resin, because it has more conservative, have less risk of pulp exposure, and of course, the presence of the dense invaginatus. Management of congenitally missing maxillary lateral incisors. Tooth agenesis is one of the most common dental anomalies and can be defined as the congenital absence of one or more primary or permanent teeth. Tooth agenesis of permanent dentition is commonly observed in the third molar and followed by the mandibular premolars and the maxillary lateral incisors. Treated planning options for the congenitally missing lateral incisors are either orthodontic space closure by canine substituting for the lateral incisors and reshaping the canine to mimic the lateral incisor form, or by prosthodontics involvement approaches with or without orthodontic space opening. But usually they do orthodontic space opening with management of congenitally missing maxillary lateral incisors. Kinzer and Kokich in 2005 suggested that various factors should be evaluated before selecting the suitable therapeutic options, such as patient age, type of malocclusion, presence or absence of crowding, facial profile, canine size, shape, and color, tooth size, proportion, and smile level. The authors also suggested that the types of malocclusions that present better final outcomes with the canine substitution are either patients with straight to slightly convex facial profile with a class 2 malocclusion with no crowding in the mandibular anterior teeth, or patients with a class 1 malocclusion with mandibular anterior crowding that necessitate tooth extraction. The author in the review, they also offered a systematic way to apply this concept of canine substitution. As you can see, first you do enameloplasty for the cusp tip, then enameloplasty for the mesial and distal side, then reducing the labial ridge. As you know, the canine has a very prominent labial ridge. Then composite build up for the deficient part, and the last step is building the line angles. This case is about 13-year-old female with maxillary missing lateral incisors and complained of space between her anterior teeth, as you can see. Not only the diastema, also the generalized spacing. She presented with a class 1 malocclusion associated with retroclined mandibular incisors, normally inclined maxillary incisors, and protrusive lips. It was decided after discussion with the patient and her parents to manage the malocclusion by following space closure for the missing lateral incisor and mandibular second premolar to avoid future need for prosthetic interventions and implant surgeries. Simply, they went for the space closure in order to avoid a future prosthodontic trinity plan. And as you can see in this right bottom figure, when they applied the brackets, they took into consideration that this lateral or this canine, sorry, this canine and this canine would be reshaped and substituted into the lateral incisor. So they inserted the brackets at the very center of the tooth and give an opportunity for scanning to scan the whole tooth in order to do a diagnostic setup for the tooth, as we said, or as we saw before. In this case, the diagnostic setup were three. They discuss with the patient the most aesthetic diagnostic setup. The first one, only reshaping for the maxillary canine. Second one, reshaping for the canines and the central incisor. And the third one, reshaping for the maxillary incisors, the canines, and the premolars. And of course, the designing was done in all of the previous cases through 303 shape design software. After discussing the different possible scenarios, the patient decided to reshape both maxillary centrals and the canines, simply by composite restoration. After that, they, from the design of the diagnostic setup, which is the second one, they printed a mock-up, then used it as a template to build up these composites. And this is the final result. You can see this canine and this canine look like the lateral. Now, the second treatment approach, which is space opening and prosthodontic replacement, which include the several treatment options that we know. First, dental implant supported crown to support the prosthesis, which also include resin bonded fixed dental prosthesis, cantilever, fixed partial denture, and the conventional fixed partial denture. Dental implant supported crown, the first treatment option, this is for the grower patients. It was proposed by Kokich in 2004 that facilitating the eruption of the permanent canine mesially into the space of the missing lateral incisor can establish a more favorable implant site development. So the permanent canine can then be distalized to develop the implant site with adequate bacolingual alveolar bone dimension that can house an implant without the need of a bone graft. Two supported prosthesis options. The first one, the resin bonded fixed dental prosthesis, which is the most conservative one. Here you usually use as an interim solution to restore single tooth space in grower patient. The disadvantage of this option, as demonstrated by Marshud in 2018, that the resin bonded bridge associated with high risk of debonding, about 15 to 20%. But still, resin fixed partial denture has some advantages like the minimal preparation, the less fabrication time and cost as compared to the conventional fixed partial denture. Kinzer and College in 2005 suggested that this option is only restricted to patients with certain clinical criteria that include shallow to normal overbite, normally proclined maxillary central incisors, and the absence of occlusal contacts on the maxillary anterior teeth. On the other hand, cases of deep overbites, mobile teeth, and increased proclination of maxillary incisors showed a higher rate of failure, particularly in patients with parafunctional habits. This case is about 11-year-old female patient who initially presented to the orthodontic clinic to manage the space between the maxillary teeth, as you can see here, due to the congenitally missing maxillary lateral incisors. After consultation, it was decided to open the space for the placement of dental implants to replace the maxillary incisors when the facial growth is complete. Of course, we need a Zen-bonded bridge. After completion of orthodontic treatment at age 14 years, the patient presented with option of restoring missing lateral incisor with resin-bonded bridge. Here, the orthodontic retainer was removed because the resin-bonded bridge itself can be used as a fixed retainer. So they did the preparation for the palatal surface, as you know, the scan file, transported to the laboratory to design the prosthesis. Then the resin-bonded bridge was fabricated from lithium disilicate. As we said, served as also as a fixed retainer and cemented with self-adhesive resin cement. This is the end result. These are the two central incisors. After the orthodontic treatment, after opening the space, it was enough for the lateral incisors. They prepared the palatal surface, as you know, then fabricated resin-bonded bridge that also served as a fixed retainer in order to prevent the prolapse of the diastema. Second option, the cantilever FDP. You know, the canine uh, can serve as a good abutment for cantilevers. But here we have two scenarios. If we don't need to cover the facial surface, the partial coverage will be enough. But if we need to cover the facial surface, for example, for aesthetic reasons, we go for a complete coverage for the canine. However, excessive eccentric contact of the pontic showed a higher risk of fracture of the restoration, loosening of the restoration or migration of the abutment. Third option, which is the conventional FDP, it's often indicated when the adjacent teeth have significant caries or fractures, or in case where there is a previous FDP that need to be replaced. And of course, the implant would be contraindicated here. It can be considered also as an option in cases that necessitate significant alteration in the facial morphology of the teeth adjacent to the maxillary lateral incisor. So with our caries, restoration, implants contraindicated, or simply we need to reshape, we need a great amount of removal to reshape the adjacent teeth. Here we need conventional fixed partial denture. Now, this case is about 13-year-old female patient. This patient presented with convex profile, competent lips, and mid-skeletal class 2. She had a class 1 molar relationship, class 2 canine relationship on the left side. The right maxillary canine and the right mandibular second premolar were impacted. You can see the impacted teeth here. So in this case, premolar canine substitution was planned. Uh, of course, they extracted the impacted teeth. Then they do orthodontic brackets in order to align the teeth. After that, premolar canine substitution was performed. The prosthodontist was consulted near the end of the finishing stage of the orthodontic treatment, as usual, to confirm the desired location of the right maxillary first and second premolars. The diagnostic setup performed by digitally copying the shape of the contralateral canine, this one, and superimposing it over the right maxillary first premolar. From the diagnostic wax template was done and printed according to the digital diagnostic setup, printed and used to build the first premolar and substitute it with a canine. Reshape it. Management of a deep bite case. This case is about a 52-year-old female who presented to the clinic asking for veneers to improve her smile. She presented with deep bites and uneven wear of the occlusal surfaces of the anterior teeth. Also had uneven gingival architecture. The tentative plan was to improve the alignment and achieve functional occlusion to minimize the amount of tooth preparation needed, combined with having a mutual protective occlusion. The orthodontic treatment spanned over 18 months to correct the bite and achieve an optimal occlusion and gingival architecture. This is after the completion of the orthodontic treatment. The dentition was scanned digitally using an intraoral scanner, and smile design was performed. Then, after the diagnostic setup, the model, as usual, was printed and used for the mock-up. The template then used also for as a preparation guide for veneers. Feldspathic porcelain was here the material of choice. The preparation was done through the professionals, then the veneers at the delivery visit, the veneers were fitted and cemented, and this is the end result. But in this case report, they didn't mention how they solved the deep bite orthodontically, unfortunately. Now let's talk about a new subject, concept of accelerated orthodontics. What does accelerated orthodontics mean? Accelerated orthodontics mean that it combines orthodontics and periodontal treatment to accelerate the process of teeth movement. Historically, they used invasive techniques in order to achieve that. To hasten the tooth movement, surgical techniques have been employed that rely on the idea that surgically irritating the bone would set up an inflammatory cascade that would promote the osteoclastogenesis and hasten tooth movement or accelerate the tooth movement. And one example on, on this technique, the invasive technique, the one you're familiar with, it's called interseptal alveolar surgery or the distraction osteogenesis, which involved gradual displacement of fracture induced through medical means. This technique leads to simultaneous growth on both soft tissue and bone volume by mechanically straining the osteotenocyte. And this is a figure to show you how it works. This is the split site, and they use this appliance to cause tension on the bone on both sides, and this tension will induce the bone formation on these sides. But it's considered a very invasive procedure. As we said, invasive, and patient didn't take them well, hence newer methods were introduced, such as minimally invasive techniques and non-invasive techniques. First method from the minimally invasive techniques is piezo-excision or piezosurgery, which means using a piezoelectric knife, as you can see in this figure. This knife will induce several cuts in the buccal cortex, unlike the distraction osteogenesis that require full thickness buccal and lingual flaps. Here, just we need to induce several cuts on the buccal cortex only, leaving the parietal cortex unharmed. And this technique can be used in conjunction with soft tissue grafts through tunnel techniques. You can see this technique is less invasive than the previous technique. Next is the micro osteoperforations, or another name called the principle of propel orthodontics. In this method, they use a device called propel, which is simply a handpiece with a round bear. This propel induces small perforations with a size of about 0.25 millimeter. And these perforations will stimulate the inflammatory markers, enhancing the osteoclastic activity, and in turn will accelerate the tooth movement. So this is the handpiece, and these are the perforations you can see. And you can notice that it's even less invasive than the previous technique. However, this technique, considered minimally invasive technique, however, it's more invasive than the previous two, called the corticotomy assisted orthodontics, another name, Wilcodontics, or periodontally accelerated osteogenic orthodontics. And as an integral part of this process, they also comprise bone grafting beside the decortication. As you can see, first they do decortication for the buccal cortex, raise the flap and decorticate the buccal cortex without touching the medullary bone. After that, they insert these particles. As you can see, this is a particulate bone graft, and close the flap. This technique is actually based on something called regional acceleratory phenomenon. In other words, means increase the metabolic activity and increase the blood flow to the site of injury, which lead to the activation or increase the activation of osteoclasts and osteoblasts, and enhance the bone remodeling process, and thus accelerating the tooth movement. This technique can increase the bone width, reduce the need for extraction, and also increase bone support for teeth and soft tissue. Remember, they usually do bone graft with it. The second group is the non-invasive techniques. First one example is the cyclic vibration. This is a technique where they apply alternating pressure to the teeth. And this technique, it's not a primary method, it's used as adjunctive to the conventional braces or the clear aligners in order to accelerate the teeth movement. And there are two known examples of these devices. The first one is Axillident and the second vPro 5. This is the Axillident. Has a simple design, two main components. This component, which called the extraoral component or the handle component or the generator of vibration component. This part generates vibration at approximately 25 gram at 30 hertz. And this is the second component, the intraoral component, which is the mouthpiece. This mouthpiece function to transfer these vibrations to the dentist in order to accelerate the teeth movement. And of course, we have the vPro 5, same concept. Second method is the photobiomodulation or the light therapy. Commercial device called OrthoPulse is an example of it. Use low level of near-infrared light energy to simulate the periodontum. And this in turn will induce the turnover and accelerate the tooth movement. Again, used as adjunctive like the vibration devices, used as an adjunctive to the braces and the clear aligners. And we have the biologic approach. This biologic approach works by disturbing the matrix, the cellular matrix, inducing the fluid movement and thus the bone remodeling and thus the tooth movement. Many examples of it, parathyroid hormone, vitamin D, prostaglandins, relaxin, neurotransmitters, NSAIDs, corticosteroids, bisphosphonates, like the herbal medicine, biomaterials, aspirazepine, and synthetic biomaterial like graphene oxide. Dr. Leila, would you like me to stop here?
Yes, this will be an excellent point to stop on because we're going to concentrate on the periodontal issues. So thank you very much, and we will meet with you after a break, and we will continue the second part of the lecture. Thank you very much.
Okay.